The ischemic heart disease spectrum. We will focus on classification, but the basic pathology is usually the myocardial ischemia caused by a critical imbalance of supply and demand, oxygen supply, and compromised coronary circulation due to atherosclerosis leading to ischemic heart disease, which may manifest as chronic coronary syndrome or acute coronary syndrome. Acute coronary syndrome is unstable angina, non-ST elevation, and ST elevation MI, while CCS has stable vasospastic variant angina, etc. Chronic coronary syndrome is exertional chest pain that is relieved by rest and with normal ECG at rest along with negative troponins and no necrosis. Hallmark of chronic coronary syndrome are stable angina. There is a fixed atherosclerotic narrowing. As we are seeing that in chronic coronary syndrome, there is a fixed obstruction, but in the spasm or vasospastic angina, the epicardial artery spasm lead to transient ST elevation, specifically during episodes with no raise in biomarker in the blood and obviously no necrosis thereby. There may be or may not be any plaque, but the plaque doesn't rupture in spasm. The plaque rupture with subtotal thrombosis in unstable angina or subtotal thrombosis with occlusion partially in non-ST elevation MI and complete thrombosis and occlusion in ST elevation MI. Unstable angina is ischemic chest pain at rest or with increasing frequency and duration gradually. The plaque ruptures without myocardial necrosis. There may or may not be subtle STT wave changes, and as there is no necrosis in unstable angina, so the biomarkers are not elevated. This is the critical differentiating point from non-ST elevation MI. So mostly unstable angina is a diligent diagnosis on history, while non-ST elevation MI will be with partial occlusion with subendocardial infarction and ST depression or T wave inversion are more obvious, but there is never ST elevation in non-ST elevation MI. The biomarkers are elevated because the necrosis has started, and this is the critical differentiating point from unstable angina and stable angina. Non-ST elevation MI has partial thrombus. When this thrombus completely obstructs the lumen, it leads to ST elevation MI, and there is a total cutoff of supply with transmural full thickness infarction, and the opening of the artery is the immediate goal as soon as possible with time limits for percutaneous intervention or thrombolytics. There may be new onset LBP with raised troponin. Biomarkers are not elevated in stable and unstable angina, but biomarkers are elevated in myocardial infarction. As the name infarction suggests, there is necrosis, and as necrosis occurs, there is breaking of cell membrane and release of troponins. In unstable angina, non-ST elevation MI, there may or may not be any changes at rest, or there may be some ST depression and T wave inversion. In ST elevation MI or vasospastic angina, transiently ST will be elevated. New onset LBBB is a STEMI equivalent. So the master diagnostic metric stable angina has stable stenosis with negative biomarkers with normal ECG and no myocardial necrosis. Unstable angina has a ruptured plaque and troponins are negative with STT changes may occur and myocardial necrosis is absent. In non-ST elevation MI, there is partial thrombotic occlusion with positive troponins, STT wave changes and subendocardial infarction. While in ST elevation MI, there is complete thrombotic occlusion, positive troponins and ST elevation or new onset left bundle branch block. There may be transmural infarction in ST elevation MI.